Yes, doctor. Yeah. Thank you for that. Now I have the next part of the question by Rishi. So his query is with regards like how can the distribution of the quality healthcare be possible to poor countries or maybe the rural areas as well?
How can the quality of healthcare be assured? Well, remember that health is still a state function in India. It's not a national thing. And so I think state governments need to look at measures of quality of care. What constitutes an appropriate measure of quality of care? Now, obviously, there are great differences throughout India. Kerala being sort of on one end of the spectrum, and I don't know, rural UP, maybe Eastern UP on another end of the spectrum. I think that by keeping guidelines straightforward and as simple as possible, we can ensure quality for the most common conditions, not for everything. But I think by setting certain guidelines and standards and then applying them and also having a good, what shall I say, good evaluation. I don't think there's been one physician in India who's lost their license because of malpractice. I don't think there's, maybe you can count one or two, but the profession itself has got to think about how do you keep bad apples out. And there's no question there are physicians or nurses or quacks and so on who are causing great harm and damage. How good has the profession been in getting those people to lose their license, to lose their ability to practice? I remember when there was a 20 or 30 deaths, I think it was in Chhattisgarh, from tubal ligation, simple procedure. I don't think anybody has ever been brought to book for what happened. What is it? Was it an act of God? Obviously not. It was somebody using the wrong medicine, using the wrong technique. Something went on and 30 people died and nobody was brought to book on that one. I find that quite incredible, unless things have changed since I was last there. But there's an old saying, we have seen the enemy and it is us. So in many of these situations, we have not taken the initiative. We have regulations for pilots. We have regulations for drivers. We have regulations for all sorts of things. And if somebody doesn't follow those and is egregious in their behavior, we have ways of dealing with it. Medical profession has done a very poor job of dealing with people who do not provide good quality and in fact provide harm, cause harm.
Thank you for that. Now I have the next part of the question is from Amrit, and I'm clubbing it with Nishi, who's the concern is with regards to the ASHA workers, wherein ASHA workers are already being bombarded with the workload of giving various data, but can we empower ASHA workers to treat the common diseases? So what is your take on that, Doctor?
Well, I think if the treatment is simple, and treatment of TB is simple, as I pointed out, and there are very clear ways of doing it, and there is a good backup. That is, with a lot of community health worker programs, people are trained, in my view, far too long, and then they're sent out there to carry out the work, and there's no supervision, and there's no continual evaluation. No business would do that. If you're selling whatever soda you're selling, or chupples or matches and so on, the distributor is also checking in on all of the shops that are doing that, and they do it periodically. So if you're going to send the ASHAs out there, I believe that frequent, short re-education programs are important. I don't think that the initial training need be that long. If you have frequent re-education programs, and you continually evaluate them on some very clear metrics. The metric should be something that relates to what they're doing and is important, not simply down there to fill out a sheet. You know, I remember a friend of mine was asked to, many, many years ago, to try to simplify the metrics of a primary healthcare system. There was something like 30 forms, one for this, one for that, one for this. And so he, after many months, simplified it, and he got it down to one form. And so what did they do? They had the 30 and then they added the one. So now there were 31 forms. Well, that wasn't the purpose of the exercise. The purpose of the exercise was to reduce the 30 forms to one form. They ended up with 31 forms. So I think simplifying, I want to again emphasize, is not easy. Simplifying is difficult. It's difficult because you have to make a decision, what stays and what goes. But it's a very critical decision because having people collect information that is no value, and they see no value, and so when they see no value, when there's no feedback, they stop collecting it, or they simply fill it in. And so you look, and every month it's the same number, 15, 15, 15, 15. That's the first tip that something is amiss. So people have to see that what they're collecting is useful. They need feedback. You know, we're no different. As students, we want to know, is this, what am I studying for? Is this, am I studying something that will be of value, of use? And then how will they evaluate that? Nothing is more aggravating to a student than to see a question on an exam that has no relevance whatsoever to what they've been studying, and they see no linkage to it. And that will be forgotten within minutes after leaving the class.
All right. So now I have this question from Jayant. He's asking, like, Doctor, with regards to this pandemic, COVID has taken away the attention, but with regards to when we compare to the other illness which needed critical care, how has this impacted on the other illness?
Well, as I tried to indicate earlier, unfortunately, not COVID itself, but the response to COVID, okay? The response to COVID, the governmental response to COVID, or the public's response, has led to certain issues. Immunization rates are down about 70%. TB treatment is down. Fewer people are coming to clinic because of heart problems. Fewer people are coming for other health problems. And so what has happened is two things. One, fear was imparted on the community. Don't go there, don't do this, don't do that. Stay at home if you have this. That was appropriate. You don't want people flooding clinics with COVID symptoms, most of which are going to get better anyway and don't require any hospitalization. So yes, that was a good thing. But at the same time, you still have to provide basic health services, not things that are unnecessary. And those basic services, many of them, in fact, could have been provided in the community by ASHAs or by a community-based system if that system was functional. Unfortunately, it wasn't functional in many places, and so care was essentially cut off. But there have been, and this is not just in India, in many other parts of the world, basic services have suffered because of this obsession with COVID-19.
All right. Yeah. Now I have this question from Mayank. Earlier you were talking like to keep the things simple when we look at medical care. But can we use technology in providing the medical facility to the major population of the India when we look at who is illiterate? When there is a illiterate population is higher, so can we look into, how do we look into that?
Well, I think technology has a place, obviously, and we are increasingly moving towards greater technologies and so on. But I don't think you can take out the human element. You know, Bangladesh is certainly as poor as many places, many states in India. Obviously, India is a patchwork of all levels of development and so on. But let us compare Bangladesh to West Bengal or parts of Bihar, UP, and so on. And we did a small study some years ago comparing Bangladesh to West Bengal, which has done better than most of India, by the way, and found that at the time of partition, 47, uh, East Bengal, as opposed to West Bengal, had much, much, much worse health statistics because all the wealth was in West Bengal. It was in Calcutta and so on. Bangladesh was sort of providing the jute and the rice and so on, but the wealth was in Calcutta. But since their independence in the 70s, they have increasingly developed statistics which are almost identical to those of West Bengal. And one of the why is a very interesting question, is a question that I'm not sure anybody has yet provided an adequate answer, mainly because doing cross-border studies is not something that's easy to do because of the politics, unfortunately. But we concluded that civil society was stronger over on the eastern side than on the western side. And that people, because of the strength of some of the NGOs and other communities, people were more civilly engaged in their own situation in terms of health workers and schools and so on. Now, whether this is true or not, I don't know. But it's interesting to compare something like open defecation. In India, it's still around 30-35%. In East Bengal, Bangladesh, it's around 4 or 5%. Why is there this huge difference? And it is a huge difference. It's not a matter of 1 or 2 percentage points. Very interesting question. Very interesting. And is this related to local initiatives? Is it related to government? Is it related to culture? There are all sorts of, I don't want to get into that issue, but it raises interesting questions. So I think that I'm very interested in comparing likes to likes. There are 3 areas, for example, in India or in South Asia, let me look at South Asia, that have done much better in terms of COVID. And those are Kerala, Sri Lanka, and interestingly enough, Nepal. Nepal, Sri Lanka, and Kerala. So what is it different about those situations, and what can we learn? Unfortunately, and I've been working in South Asia now for over 50 years, there oftentimes is a sort of competitive thing. If I do well, that means you don't do as well. This is not a competition. This is a way that, how do we take lessons from all sorts of places and apply them to our situation? So technology has a role to play. But I think in India today, at least for the foreseeable future, it will still depend upon a person-to-person interaction, if for no other reason than to interpret what that technology means. So the technology is important, but there still needs to be somebody at the end of the queue saying, well, what does this finding mean, and how can I operationalize it? So we can do better diagnosis. Certainly, we can spread messages much easier. We can, there are lots of things that technology can do. It can give us much greater access to money, issues of credit and banking. There have been remarkable changes in terms of using technologies to do this, whether it's Bcash in India or some of the programs in Andhra and so on. Remarkable stuff. But I think that we've got to be careful that we don't substitute that for still that human interaction, which I believe still is rather critical in interpreting some of that information that we're getting. But that said, technology has done wonderful things and will continue to do wonderful things if we use it sensibly.